Thank you, Elizabeth. It's great to be here. Very excited. For my talk today, I will explain a little about the cameras that we use in nuclear medicine and PET-CT. I'll explain what happens in the department before any patients arrive, also what happens with the patient, and a small example of some images. And finally, the logistics and hurdles when looking at scheduling a scan as part of a research study. But first, what exactly is nuclear medicine and PET-CT? Well, you've heard a little bit both from Maita and Jen. The most basic principle is that a radiopharmaceutical is administered or given to a patient. This can be inhaled or injected or ingested even. And then in almost all cases, we want to see what is happening to that radiopharmaceutical inside the patient. For example, where it has accumulated, and we can do this using a gamma camera. This is an example of some of the tests that would be carried out in nuclear medicine departments. As you can see, there is quite a wide range of the body's systems and organs covered. We do have a very small number of studies where we don't image the patient. Instead, we would take blood or urine samples at various time intervals after giving a radiopharmaceutical and measure the amount of radiation in each of the samples. I should also say that some hospitals have both nuclear medicine and PET-CT in the same department, and they come under the title nuclear medicine. And in other hospitals, they are separate. So apologies if I sometimes group the two together under one term, nuclear medicine. In relation to oncology, these are some of the areas that would have imaging performed in nuclear medicine and PET-CT. And I will go through a few of these in a little more detail later in my talk. So how are we different to other imaging that takes place? Well, an X-ray or a CT scan sends radiation from a radiation source to a detector on the other side of the patient, whereas in nuclear medicine, the patient is the radioactive source and the camera is detecting where it is inside the patient. And this means that as the patient is the radioactive source, everything that comes out of the patient is radioactive too. Let me explain about the cameras that are used in nuclear medicine and PET-CT. On the left is a gamma camera. On the right is a PET-CT camera. The gamma camera has two heads, which are the two box-like structures in front of the donut. These can rotate and be moved into a variety of configurations. Originally, gamma cameras did not come equipped with a CT component. However, this has changed, and over the last 20 years or so, more and more gamma cameras are installed with a CT, even though the day-to-day working name has stayed as gamma camera. On this gamma camera on the left, the CT is the small grey box in the 12 o'clock position on the donut. The PET-CT camera on the left is a long, large donut, which has a ring of radiation detectors and a CT scanner all incorporated into the one machine. Each head of the gamma camera is made up of a collimator, a sheet of scintillation crystal, a light guide material, and photomultiplier tubes. The collimator is a thick lead sheet with holes in it, as shown in the right-hand image. As radiation comes out of the patient in all directions, the collimator only allows the gamma photons traveling in a particular direction through to the crystal. The gamma photon reacts with the crystal to give off a tiny flash of light, which is seen by the photomultiplier tubes, and over time, all the light flashes that have occurred in the crystal build up to create an image. Just to recap what Maita previously described, PET stands for positron emission tomography, which is exactly as it says. The radioactivity that is used emits a positron. This positron annihilates with an electron, which results in two gamma photons that travel in opposite directions to each other, which we take an image or tomograph of. For this reason, instead of having a head like a gamma camera, the PET camera is made up of individual crystals arranged in a ring around the patient. And as the crystals are separated from each other, it also means that there's no collimator required. With each of the detections of the gamma photons, some very fancy computer work is able to map back where the annihilation that led to that pair of photons has occurred in the body. On the left, you can see a schematic of how the CT is built into the camera. And as a CT of the patient is taken at the same time, the two images are able to be fused together. It is very important that the patient remains as still as possible for the duration of the imaging. Otherwise, significant movement will cause difficulty fusing the two images together, or at worst, parts or all of the scan would have to be repeated. I'll show a few images later on in the talk. Now let me move on to what happens in the department. Most departments will start very early in the morning to get the cameras up and running. The daily QC of a gamma camera and a PET-CT camera can take about half an hour to 45 minutes. And some days we'll have additional weekly tests carried out as well. And it's very important that all the QC is passed prior to injecting the first patient. The gamma camera will have a daily flood performed, it's called. The flood is made up of a uniform sheet of cobalt-57 in a hard plastic covering with no blemishes or bubbles in it. This means that if there is anything odd on the image, it is something going on with the camera. You must be really careful not to drop a flood, as you don't want to do any damage to it or the cobalt to leak out. This is a picture of what a normal flood would look like. It should be nice and uniform in appearance with no marks or anything. Not like any of these images, which is not what any technologist wants to see first thing in the morning. For the PET-CT camera, this is what a QC image would look like. You can see all the individual crystals. Again, the appearance of them is very uniform, which is a good sign. Not like this image. Here is an example of what it shouldn't look like. Again, you do not want to see this when you're preparing for a day's list of patients. The dose calibrator is checked every morning using a cesium source. During the day, the dose calibrator is used for measuring all the doses that will be given to every patient. So it is very important that it is working accurately and correctly. When the radiopharmaceuticals arrive in the department, they are all measured and checked for a number of reasons, to make sure that there is sufficient activity for the patients that will be attending, but also to keep a track of how much radioactivity is being held on site at any time, how much has been administered to patients, and how much has not been used and therefore going to waste. Dan McGann will explain a little more about this later in his talk. And sometimes accidents happen. This is a vial that was recently delivered to a department which was discovered to have cracked in transit. It meant that a number of patients had to be rescheduled for another day, which was unfortunate as the patients had to fast for a minimum of 4 hours prior to arriving, and some had travelled quite a distance. To summarize some of the differences between nuclear medicine and PET, you can see that the energy of the radioactivity used in general nuclear medicine is much less than in PET, which is 511 keV. And there are significant differences in the length of half-lives. PET is usually always measured in minutes, whereas nuclear medicine is measured in hours, and some is even measured in days. I've talked a lot about the equipment that we use, but all of this is nothing without our patients. So I'll now go through in general what happens to a patient when they come through to the department. After the patient arrives, they will usually have a short chat with one of the imaging staff. This is to make sure that they understand why they have been asked to attend and to explain what will happen, to check that they have followed any particular preparation required if there's any for that particular test. And to find out if they've had any injuries or surgery or previous cancer treatment, as this could affect their imaging. For example, if a patient is attending for a bone scan and says that they recently fell in the bath and bruised their chest and ribs badly, then if the radiologist sees anything in that area, it could be attributed to that injury. And obviously you want to know in advance if your patient is likely to faint when you go to inject them. Administration of radioactivity to a patient is a highly regulated area. The person who refers the patient for the scan must be a registered healthcare professional as defined in IRMA regulations. This referral is then justified and authorized by a licensed practitioner under RSAC. For novel research radiopharmaceuticals, it may be necessary to update the practitioner's RSAC license. Dan McGann will explain about the different regulations in a little more detail in his talk later. As a technologist, our checklist is that the referral is justified and authorized by the licensed RSAC practitioner, that we have the right patient, we have the correct pharmaceutical, the correct dose for the correct procedure for the clinical question. This is some of the equipment that would be in a nuclear medicine and PET-CT departments for drawing up the radiopharmaceutical injections and the disposal of syringes afterwards. Due to the weight of shielding required for a vial in PET-CT, automatic dose dispensers are used in many departments. I'm sure you can appreciate that the weights of the vial shields, syringe shields, and the syringe carriers are quite significant when being used by staff multiple times a day, every day. All staff that work in nuclear medicine and PET-CT are monitored to check how much radioactive exposure they are receiving. One method of doing this is by using finger monitors. On the left, you can see 2 finger monitors being worn, one held at the top of a plastic sleeve over the finger and the other in a ring at the base of the finger. These would be worn underneath gloves, and it has a noticeable impact on finger dexterity. On the right, you can see a simulation of a radioactive injection. This requires a certain amount of skill, as the shielded syringe containing the radiopharmaceutical can be quite tricky to attach and detach from the cannula due to its weight, and to make sure that the radioactivity doesn't drip anywhere. I've always said if I had an additional 3 hands, it would make injecting so much easier. In nearly all cases, unlike CT or X-ray, the patient has to wait after the injection while the radiopharmaceutical is taken up by the relevant area of the body in order for a good quality image to be formed. These are examples of some of the time delays between injection and imaging. If the patients are imaged too soon or too late after injection, the images will not be of optimal quality for reporting. Most nuclear medicine departments will have a separate waiting area for patients that have had a radioactive injection, and for PET, patients will have their own cubicle to wait in. Unlike CT and X-ray, you can see from these times that our images take quite a bit longer to form. It is important to know if a patient is claustrophobic or has difficulty lying reasonably flat for any particular length of time, or if they have any continence issues. From this slide and the previous one, I hope it shows that you can't just inject all your patients at 10 o'clock in the morning if you only have one camera to image them all on. Also, as well as thinking about how much radioactivity you have left, you have to think about the expiry time of the product. As has been mentioned by Jen and Maita, the radiopharmaceuticals are usually made very early in the morning, and their shelf life may mean that they have expired by, say, 2 o'clock that afternoon. I'm sure you can appreciate that from this slide and the previous one, getting the timings right is very important. And one other big difference from CT and X-ray, our patients are still radioactive after they finish the scan. General advice to patients will be about keeping their distance from other people. However, at the moment, everybody is doing that. For an inpatient, ward staff will be advised to keep their distance as much as possible and to store any linen or waste items in a separate area for a designated length of time before they can be disposed of, which is to allow for any possible radioactive contamination to have decreased to safe levels. Patients will be advised the time that they will stop being radioactive at. If they were traveling abroad in the days following the procedure, patients are provided with a letter detailing the injection they had in case it alarms any radiation detectors in the airport. I've talked about some images, but I haven't shown any yet. Here you can see 2 examples of a bone scan. The image on the left is a normal, regular bone scan, whereas the image on the right shows a patient with multiple bone metastases in 2 different grayscales. Bone scans are most commonly used to show breast, prostate, and lung cancer metastases. All bones are repairing themselves all the time, but when they are damaged, the repair is much more obvious and appears as a hotspot or darker patch on the scan. For the purpose of this talk, I've taken 2 very contrasting images, but you remember I mentioned my patient who fell in the bath. The image might show the only hot areas on the ribs, which are repairing from the fall. Therefore, it is important to know the patient's history so that the radiologist can accurately report the scan. A cardiac mugger scan is used to calculate the ejection fraction of the left ventricle of the heart, or in simple terms, how well the left ventricle is squeezing to push the blood around the body. It can be used in cases where patients are having treatment, so that may damage their heart. For example, the breast cancer treatment, Herceptin. The patient is connected to an ECG, which takes the heart rate of the patient for the duration of the scan. Each heartbeat is divided into sections, which the computer is then able to add all the individual sections together to give the image on the right, which is a summary image of one heartbeat. Also, with the images that are required, a region can be drawn around the left ventricle to calculate how well the heart is pumping, which gives us a percentage value. In this example, it is 60%. Anything above 55% is considered normal. Patients may have this test prior to starting treatment and then at regular time intervals during their treatment and possibly afterwards as well. For example, every 3 months to check how their heart is and to compare it to the original baseline measurement. Sentinel lymph node localization is commonly used to identify the closest lymph nodes to the tumor in breast and melanoma cancers. These lymph nodes can then be identified during surgery using a special radioactive detector, removed and sent to pathology to be examined for any metastatic cells. This technique reduces the need for all lymph nodes to be removed, and therefore this reduces the risk to the patient of developing lymphedema in the future. This is a SPECT-CT or 3D image taken of the pelvis to show the lymph nodes relevant to a melanoma on the leg. While the technique of sentinel lymph node identification is predominantly used in breast and melanoma, there are many studies investigating its application in other cancers, for example, head and neck, cervical, endometrial, and prostate. This is a PET-CT scan, which is showing the presence of a liver tumor. On the left, you can see the CT scan. In the middle, you can see the PET scan. And on the right, you can see the two images fused together. Combining the images really makes a difference in being able to accurately see the location of the tumor. As I mentioned before, it is important that the patient remains as still as possible for the duration of the scan, as any movement can lead to difficulty in fusing these two images together, and at worst, having to repeat parts or all of the scan. Here is an example of a PET-CT scan showing esophageal cancer and two metastases, one a lymph node and the other the left adrenal gland. It is also possible to see some uptake in the kidneys and the bladder. This is because the radiopharmaceutical is being excreted via the urinary system. It is important for patients to drink plenty of fluids and go to the toilet often. It is worth mentioning that not all areas where there is an increase in radiopharmaceutical is a bad sign on images. Depending on the properties of particular radiopharmaceuticals, they may naturally show in the heart, the brain, the liver, digestive system, or urinary system, as well as any cancerous areas. If a patient is cold after injecting, there may be uptake in the brown fat of the patient, as can be seen in the set of images on the left-hand side. And if a patient has had a particularly strenuous session at the gym the day before, then there may be quite a bit of muscle uptake, as can be seen on the image on the right. For the final part of my talk, I would like to go through some of the obstacles and things to think about when scheduling a scan for a research trial, and give 2 examples of trials that I've had to schedule scans for. Many trials that have imaging as part of the trial will require the department to undergo a qualification procedure for each camera that will be imaging patients. The comprehensiveness may depend on how much the imaging is part of the trial question and outcomes. For standard of care imaging that is being performed as part of a trial, information on the cameras that will be used may be sufficient. But if the imaging is a key part of the trial question and outcomes, a much more extensive qualification procedure may occur. This could include a visit to the site, sample QC information and images, sample patient images being sent for independent analysis by the imaging lab. I did have a trial whose qualification of the camera required a total of 2.5 days worth of imaging, which was extremely difficult to schedule around a full-time working department. Most research trials have generally 3 main parts where imaging will be required. Screening, which is after consent but before randomization or treatment, while the patient is having treatment, and during the follow-up period that the patient is monitored after having treatment. For the second 2 areas, treatment and follow-up, that's usually not too difficult to schedule your imaging at the appropriate time point. But with the screening period, it can be a little bit more tricky. And let me explain a bit more about why that is. I think you may have heard from Jen that most departments work on a 5-day week basis. And as you heard from both as well, radiopharmaceuticals have to be produced every day, which means if the radiopharmacy doesn't produce, then you can't inject and scan patients. Some radiopharmaceuticals may only be produced on certain days, as it can depend on the amount of radioactivity that is available to use. For bank holidays, what would usually happen on a Monday is then moved to a Tuesday. And this might be things like weekly maintenance of the cyclotron or weekly cleans of the radiopharmacy. These can affect the timings of the workload of radiopharmaceutical production on those Tuesdays. As I mentioned before, the patient continues to be radioactive after they have finished their scan. It is therefore advised for them not to have any other tests done afterwards on that day. If multiple nuclear medicine scans are required, there may have to be a minimum gap between them in order that the radioactivity from one does not interfere with the images of the second. For example, a cardiac MUGA and a bone scan should have an absolute minimum of 48 hours between both injections, but longer would be preferable. For radiopharmaceuticals that are required, a routine one would usually take 1 to 2 working days. However, a novel research radiopharmaceutical may take much longer than that. For example, the kit or equipment may have to be ordered in specially, as it may not be kept in stock. There is also the question of scheduling the scan itself. There may be limited capacity in the department at that particular time. Also, just as radiopharmaceuticals may be produced on certain days, this means that those corresponding scans will take place on certain days. As I showed previously, our imaging can already take some time to be performed. And if a trial has particular requirements like additional images or imaging for a longer amount of time than usual, then this may affect when it can be scheduled on the camera. Let me show an example of a trial where imaging is required. In this trial, after confirmation that the patient was eligible, the patient commenced a medication. The 2 PET-CT scans were part of the investigation to see the effects of this medication on the tumor. The PET-CT scans had to have a minimum of 8 days between each other in order to allow some time for the medication to take effect. The supply of the radiopharmaceutical would only be delivered on a Tuesday, but not in the weeks that there were bank holidays. And the treatment had to commence 28 days after consent was received. That all sounds relatively straightforward, yes? Well, not quite. Here is what that timetable would look like on a practical sense, trying to fit all the requirements into an actual plan on a calendar. In an ideal world, the scans could have been performed on days 9 and 23 of screening. However, now day 9 is after a bank holiday, which rules out having the scan on that week. Then, if the first scan took place on day 16 of screening, you can see that ideally to allow for a minimum of 8 days between each scan, the second scan would take place on day 2 of treatment. However, both scans have to be completed prior to commencing any treatment. Here is another example of a trial with nuclear medicine imaging. A bone scan and a PET-CT scan had to be performed in the screening period of this trial. The bone scan and all other eligibility tests had to be completed, and the patient confirmed as eligible prior to requesting the PET-CT. There was a minimum of 5 working days notice for the PET-CT and a minimum of 3 working days for the report to come through. And if confirmed eligible on the PET-CT, then the patient could be randomized. The trial treatment had to commence within 14 days of randomization. And remember the bone scan? Well, that had to be within 28 days of the start of treatment. If not, it would have had to be repeated. This is a timeline of all those time points that I mentioned in the previous slide. You can see that the bone scan has to be as late as possible in the screening period, but still early enough that there is time for the PET-CT scan to be completed, but still within the 28-day time frame of the proposed treatment start date. Apologies for the amount of information on this slide, but this shows how the timeline actually fits into a 5-day working week. In this case, it was really fortunate that the bone scan and the report were all completed on the same day, which allowed the eligibility to be confirmed and the PET-CT request to be sent through later that same day. Then the PET-CT was performed 5 working days later, after which the report was sent through to confirm that the patient could be randomized onto the trial. Treatment was then started 13 days after randomization, which was just within the 28-day timeframe, so that the bone scan did not require repeating. So how can these obstacles be overcome? Well, preparation is key. In all the trials, the patient has to have a minimum of 24 hours to consider whether they wish to participate or not. And this time can be used to highlight to departments that there may be an upcoming patient and to speak to them about their schedules. For example, check to see if they have any planned engineering that could take a camera offline for a day or two, especially if trial scans are only performed on particular cameras in the department. Plan a patient diary to see how everything will fit together, especially if you know that there are upcoming bank holidays, which could affect the supply of radiopharmaceuticals or shorten the availability of imaging time that week. It's always good to have a backup plan and think of things that might happen. For example, if there is a radiopharmaceutical production failure, you are likely only to find out that morning, and you may need to completely rejig the plan and what is going to happen on that day. And I can definitely say that this can happen, as it has happened very recently to us here in Oxford. Once you have a plan, some departments may allow spaces to be reserved in their diary. I have found that this is always easier, and it's easier to cancel a space than to try and book one at the last minute. Where possible, coordinate tests to happen on the same day. For example, an ECG, blood tests, and a CT scan could all be done prior to having a bone scan injection and imaging. It can take a little bit of toing and froing to get it all organized, but the patient is really going to appreciate it, as it reduces multiple journeys for them, especially if they live quite a distance from the hospital. And if you know that there is a tight turnaround time for requiring the report of a scan, try and speak to the radiologist that will be reporting it, just to highlight that it is for a clinical trial. I hope you've enjoyed listening to my talk. Apologies that it was such a speedy run through of all the information, which was just the tip of the iceberg in relation to what happens in nuclear medicine and PET-CT. And I will now hand back to Elizabeth.